Welcome to this webinar, which is on understanding self-harm and suicide. This is part 5 in the webinar series, and in this session, we're going to focus on risk assessments. When we do risk assessments, we should also consider the wider risks, such as risks to other people, risks from other people, such as of abuse or exploitation, risk of vulnerability and deteriorating mental health, etc. However, as this session is all about self-harm and suicide, the risk assessment is going to focus on risk of self-harm and suicide. One key message in this webinar is that there is no accurate risk assessment tool to predict suicide. There are no validated tools that can accurately predict suicide, and risk assessments are not about predicting suicide. There are many reasons why risk assessments are not accurate predictors of suicide. If you watched the previous webinar, you'll remember that in the UK, there were 6,500 suicides in 2018 in a population of 65 million. Therefore, suicide or completing suicide is not that common compared to the number of people who report suicidal thoughts or suicidal ideas. So when it comes to risk assessments, they are subjective, and they are affected by the experience and the anxiety level of the clinician who is assessing. So if the healthcare practitioner assessing the patient is very inexperienced and very anxious and does not feel comfortable with assessing patients with mental health problems, they may be more likely to put somebody in a higher risk category or more likely to refer them for a further assessment by the mental health team. In addition, you may only have limited information in front of you. So in the areas that I work, we do not have access to the mental health records. Therefore, I can only base my risk assessment on the information that is available in front of me or the notes that are available in front of me. And risk assessments depend on what the patient is willing to share with me and the information available at the time of assessment. Suicide can be very unpredictable. Many will not disclose their plans or intent to self-harm to the healthcare practitioner. However, our risk assessment can only be based on the information that the patient is willing to share and the records available to me at the time. So when it comes to a self-harm or suicide risk assessment, we should use information from the full assessment to come up with the assessment of risk. So we start off with taking a history. We need to consider, what are the current symptoms? Do they have depression or psychosis? How severe is it? We need to think about their past medical history. We need to think about their past mental health history. We need to think about their substance misuse history and self-harm history, as these are risk factors for completing suicide. We need to do a mental state examination. So that's an examination of the patient in front of you at that time. So we need to think about, at the time you're assessing the person, what are they telling you? Are they currently suicidal? Have they expressed any current suicidal thoughts, plans, or intent to hurt themselves? And then we put that information together and think about the assessment of risk, thinking about the risk factors and the protective factors for that person. And we can also broadly put people into risk categories, and the simplest way of doing that is to put someone into low, moderate, or high risk. Of course, not everyone will fit into those simple boxes, so we can also consider low to moderate or moderate to high. Some people may want to say very high risk, but as a simple way of categorizing risk, we can think of as low, moderate, and high. And once we've thought about the risk of self-harm and suicide, and we've considered the severity of the suicidal intent, we should use that information to make a plan for that person, an individualized plan. So it's not about predicting suicide, it's about making an appropriate plan for the person in front of you. So if somebody you have seen is assessed as being low risk of self-harm and suicide, The most appropriate thing might be just to safety net, give them advice on what to do if things deteriorate. And if you see somebody and you've considered that their risk of self-harm or suicide is high or very high, then we might need to consider whether they need to have a mental health act assessment or be admitted to a hospital to contain that risk and for their own safety. So as I mentioned before, we can simply categorize people into low risk, moderate risk, and high risk, though I also mentioned beware, because everyone will not neatly fit into one risk category. So sometimes you may consider someone to be low to moderate risk or moderate to high risk. And there really isn't any exact definition of what low risk, moderate risk, and high risk is. So there is an element of subjectivity when it comes to putting people into low, moderate, or high risk. So we should be performing and documenting a psychosocial and self-harm assessment and an appropriate safety net plan for anyone who has presented with current suicidal thoughts, who has disclosed a past psychiatric history or self-harm history, has been arrested for a significant life-changing offence. So I'm thinking about those of you like myself who work in police stations, and there may be somebody who has a job as a teacher who's been arrested for child pornography offences, and that is a significant life-changing offence for that person. So we need to think about what support they need and whether they are at risk of self-harm and suicide. Another situation is whether somebody's a driver and they've been arrested for driving under the influence of drugs or alcohol. That is going to be significant and life-changing for that person. And of course, anyone who's experienced significant trauma, so those who attend the sexual assault referral centres, having experienced sexual assault, will also need a self-harm risk assessment completed. So when I'm doing my assessment of self-harm and suicide risk, I make sure I've thought about these 5 questions. So number 1, on the history taking, have I considered whether the client has any symptoms or signs of serious mental illness? So by serious mental illness, I am talking about moderate to severe depression rather than mild to moderate depression. I'm talking about psychosis, bipolar disorder, severe emotionally unstable personality disorder. So number 2, have I really considered whether the client has any mental health history that's relevant or any previous self-harm history? Have they recently attempted suicide? When? Are these attempts escalating? Number 3, so this is moving on to the mental state examination, which is the examination of the person in front of you. So at the time you're assessing them, have they got any current suicidal thoughts, current suicidal ideas or plans, or any current intent to hurt themselves? Number 4, have I really thought about the risk factors and any protective factors? And then finally, number 5, after putting all that information together, I make a decision based on my clinical opinion, what I believe the risk of self-harm to be. And we can write risk of self-harm to be low, moderate, and high. And of course, not everyone fits into those categories. We can consider the risks as the imminent or immediate risk. And then we can think about the medium-term and long-term risks. In the setting we work in, which is in police custody and in the sexual assault referral centres, we tend not to follow up clients. So we predominantly want to make sure that the patient is safe to be released from the police station or safe to be released after the SARC examination. So we're predominantly thinking about what their risk of imminent or immediate self-harm appears to be. So this is a very useful risk assessment tool that I've found on the Faculty of Forensic and Legal Medicine website, and it's actually produced by British Transport Police and the University of Oxford, and it's a suicide prevention and assessment aide memoir. So it's not meant to be for healthcare professionals, it's meant to be for people who are police officers. who may come across someone who is suicidal, so British Transport Police, who may come across someone suicidal on the tracks. And these are the sort of questions that people can ask. So you don't have to be a qualified medical professional to ask these. And if you do all 18 of these questions, you will have a better idea of somebody's risk of suicide and self-harm compared to if you just do a few of these questions. So I won't go through all of them, but the main questions are the ones that are highlighted in red. So are you thinking about suicide? So that's about the current suicidality. Do you have a specific plan to kill yourself? Do you have access to any of these methods? Have you ever self-harmed or attempted suicide in the past? Are you suffering from mental health problems? And do you feel that the future is hopeless and that things cannot improve? There are several other questions. Have you been drinking in the last few hours? Do you have a problem with drink or drugs? Do you have friends or family who you can turn to for help? I wanted to mention a few comments from the latest Royal College of Psychiatry guidance on self-harm and suicide in adults, and this was recently published in 2020. The current approach to risk assessment and responding only to those identified as high risk is fundamentally flawed, and the use of terms such as low risk or high risk is unreliable, open to misinterpretation, and potentially unsafe. The absence of risk factors does not mean the absence of any risk of suicide. I hope that one is obvious, as many people who do end their lives by suicide do not have significant risk factors and do not tell healthcare professionals that they are feeling suicidal. So for a variety of reasons, for example, stigma, shame, fear, or embarrassment, people may conceal or minimize their suicidal thoughts. Moreover, suicidal thoughts and risk can vary across a relatively short period of time. The assessment of suicide risk by the clinician needs to be individually focused and carried out regularly. One of the key points from that comment is that we cannot rely on risk assessments made by healthcare professionals who have seen the client already. So the key points from this session are: completed suicide is uncommon. However, self-harm and suicidal thoughts are relatively quite common. We need to take the time to explore about suicidal thoughts, make sure we have done a good enough history and mental state examination and thought about those risk factors and protective factors. The suicide risk assessment is not accurate to predict suicide. Predicting suicide is not the aim of a suicide risk assessment. We need to do a thorough risk assessment and consider the client's problems and think of an individualized safety net plan for all who could be at risk. So that takes us to the end of this session. In the next session, we're going to talk about safety plans. What exactly is a safety plan? What makes a good safety plan? And we're also going to talk through some scenarios.